Yes, and it's my pleasure to introduce the next speaker, who is Adrian Brown. He is a senior research fellow and lecturer in nutrition and dietetics at University College London, and he will speak about stigma in healthcare. I hope Lee remains online. If not, Lee, just I want to thank you for your intervention. I hope that the connection will last.
I will stay on the line.
Thank you very much, Francesco, and thank you very much for inviting me to talk today. I think today's really come together beautifully. We've had a consistent message across all the presentations around the challenges of stigma. Today, I'm really going to be focusing on stigma in healthcare, and we have been having some splatters of this through the process. Are we there? Yeah. Cool. So today I'm going to be talking about weight stigma in healthcare. I'm going to be talking about in dietetic practice and sharing some unpublished data around that we've recently done. We've got some discussion around training. That has been something that's been discussed. What we say matters, and also a little bit of a summary. So what emotions, and this is a question to everyone, so let's get a little bit lively, stop going on TikTok or whatever you're on. But what feelings and emotions would you like to feel when you see a healthcare professional? Reassured? Safe? Anything else? Confidence. Yeah, competence, yes. Listen to. So these are some of the words that have come out before: hope, not feeling blame, supportive, positive, optimistic. However, data has shown that when asked around what healthcare professionals think of people living with obesity, these are the words that are used: non-compliant, lazy.
Oh, sorry.
I'm going to take this off my time, by the way.
No, where's the... Sorry. Why is this not... sorry. It's not...
I'm getting lots of blinking, aren't I?
Yeah. Something strange is... Where's all the settings on here? Maybe it's that. Let's hope.
Am I back up? I'm back up. Woo! Okay, so fantastic. So I got to lazy. Oh, I can't see my slides now, but just 2 seconds. Where are my slides? Oh, there we go. Is this one? Yeah, that's one. Oh, no, I still can't see them. There we go. Yeah, fantastic. So weak-willed, dishonest, unsuccessful. Imagine going to your healthcare professional, your GP, and them thinking this about you. So it's really important that we wonder why people living with obesity are not engaging with healthcare. We wonder why people living with obesity are not returning to the healthcare professionals or seeking guidance from people. So let's start to talk about weight stigma in healthcare. So we see this across all healthcare professionals. This is data from Rebecca Poole, identifying that 69% of doctors, 37% of dietitians, and I'm a dietitian, so this is a shocking statistic, nurses and exercise professionals, all when questioned, whether this be questionnaire data or actually through qualitative data, have identified stigmatizing opinions. Unfortunately, this is not just limited to those people seeing people outside of obesity. For experts specifically specializing in it is also there. Now, I don't have time to talk about the very important topic of the lived experience, and we've got some fantastic people here. Thank you very much, Vicky, for sharing your lived experience today. But the qualitative reports, when you look at the experiences of patients, reflect a lot of what I'm going to be presenting today. Education within healthcare plays an absolutely pivotal role within the perceptions and attitudes of healthcare professionals. But it also might actually exacerbate pre-existing prejudices and biases. So it's appreciating that if you are teaching, it's important that you appreciate that stigma will impact on that. But stigma attitudes, and Stuart very nicely talked about this morning, about where do we get this from? We get this from this constant, consistent exposure to stigma from the media and wider settings, but also there's a lack of education around learning and around obesity to actually on how to avoid a bias as well. But it's important to understand that this directly impacts on screening and treatment for people living with obesity. And very timely, this is a new systematic review that got brought up by Helen and Teller, published actually within the last 10 days from Brazil, that looked specifically at obesity bias in medical decisions. And so what did they find? They found that it impacted on medical consultations, additional treatment, and preventative screening. As we heard today, women seem to be more vulnerable to this, particularly less smears ordered, less cancer screening for colorectal cancer, and less mammograms found in 75% of the studies that were reviewed. It impacts on the quality. It impacts on less eye contact. It impacts on less confidence of the professional believing that the person can comply, but also a lower performance of actually people feeling that they want to give a physical examination within that setting. But also, and I think importantly, Stuart mentioned it today about medications, and obviously we've got the flurry of medications that are now coming through. What impacts on medications? We see that people living with type 2 diabetes, and Daniela mentioned it today, actually they're less likely to intensify treatment for people living with type 2 diabetes and obesity. But also, interestingly, for those living with depression, they're more likely to intensify those, but with medications that promote weight gain. So we're in this challenging situation where we're seeing this completely impact on care. But let's think a little bit further. Let's think about those beliefs. And we mentioned very nicely, Francesco talked a little bit about this morning, about what do healthcare professionals believe are the main issues. And unfortunately, they mirror what we see in society. They mirror the idea that it's a lack of physical activity, it's overeating or emotional eating. And Francesco mentioned the ASK study today. So this was a group of healthcare professionals and also public that were asked a variety of different questions. This was asked about what causes obesity. And you'll see we've got the general population and the healthcare professionals and different things that are causing it. But I like to identify emotional eating, nearly 30%. We can see that, yes, the malfunction of the physical mechanics also plays a role. But unfortunately, some healthcare professionals believe that gluttony is a cause of obesity, really identifying that actually what we're seeing is actually a misrepresentation between what the evidence is saying and what people believe. But then when they were asked whether obesity, and you showed some of this data earlier, could be prevented or cured simply through following a healthy, balanced diet. We see nearly 60% on the C diagram of healthcare professionals identifying that obesity could be prevented by simply following a healthy diet, or even cured by a similar amount. And we see that very differently for other health care conditions that are again impacted by obesity. But I'm going to talk a little bit about today. We have, myself and Stuart did some work looking at weight stigma in dietetic practice. This is unpublished work, so it's currently under review. So we surveyed 402 dietitians. We looked at normal predictors. We looked at explicit bias, so we asked questionnaires. We looked at implicit bias, so that internal bias. But also for the first time, we asked dietitians how, if they experienced stigma within practice and before. So also dietitians living with obesity. And what we experienced is 50% experienced it pre-surgery, pre-registration, and nearly 60% experienced it during their career. But interestingly, this stigma was impacting on people's belief about their ability to do their role. And it impacted on dietitians wanting to work in obesity and bariatric surgery care. They wanted to hide. They did not want to be in front of someone saying, lose weight. So it's really impacting on career decisions. We did notice that there was explicit weight bias. There was a moderate belief around obesity being controllable, but also there was implicit weight bias there as well. But we noticed this across the weight spectrum. It wasn't just dietitians living with obesity. It was also dietitians living with lower body weight as well. But it was those throwaway comments that had a huge impact on dietitians working in practice, commenting on people, how they look, commenting on their weight, commenting on what they were eating. So think about those conversations that you have with colleagues about what they're eating for lunch, how they're looking. Those can have significant impacts on patients' career. On the careers of healthcare professionals. But when asked about their experiences, three key experiences came up. Experiences of stigma in dietetic practice, the impact of that weight stigma, and also the implications of their weight and their feeling and their appearance in jobs. But we've spoken a little bit about today about can training help, and this was a publication, a review that we did with Professor Rachel Batteram and Anastasia Kalia over at UCL. And what we did is we looked at whether we could reduce down healthcare stigma in healthcare, and what we addressed is key factors that have come out today. So 5 key reducing factors were identified. One was increasing education, knowledge about stigma. The other one was this causal information and controllability. The next one was actually invoking empathy. Getting people to speak to people living with obesity can change people's perceptions of how they view people. Weight inclusive, not just focusing on weight as the issue, and then mixed methods using causal empathy and awareness. What we notice from the data is that, yes, in the short term, these things can have an impact. But the issue that we mentioned earlier on is that they only happen in the short term. They happen, and then 6 weeks later, they measure it. This doesn't happen all the time. And hopefully we'll talk about this later on, about the idea of mandatory training, etc. But this should happen early on and continuously through education and practice. And we need to be targeting these key factors from the evidence that we know impact on people's weight regulation, as Professor Kaplan talked about before. But finally, what I like to talk about is what we say matters. Now, I hope that many of you will have heard about the discussions around language that we use, and you'll appreciate that we've been using person-first language today. But for those that haven't, it's always important that we reiterate this point, because we often fall back into old behaviors if we don't consistently remind ourselves. We know that those initial conversations can be incredibly impactful on those future conversations and the relationships that we have with our between patients and healthcare professionals. Poor communication can impact on engagement, motivation, but most importantly, developing that relationship. And particularly for people living with obesity, talking about body weight, that's incredibly important. We know that neutral words, when we look at it, things like weight and unhealthy weight or BMI, tend to be the most preferred terms when we actually look at the data. And the words quote unquote obese and quote unquote fat tend to be the most disliked. But ambiguity still remains. And so myself and Stuart did some work a couple of years ago looking at the preferred preferences of both preferences and emotional responses to weight-related terminology for healthcare professionals. I'm just going to represent the adult data here. And what we found is that weight, unhealthy weight, and overweight tended to be those most preferred terms. But the least preferred terms were super obese, chubby, and extra large. And what's important is when we ask people about their emotional response, a lot of them, the most consistent message was around fear. And so it's understanding that the words that we say also have an emotional response on the people that are in front of us. And this is some lovely data that was done by Obesity UK on Language Matters, and I can see some of the people in the room that were actually involved in this. But I'd like to talk about some of the things that is important when we're sitting there. Seek permission to talk about weight. Don't think that it's our right, just because someone is sitting in front of us, that we should be able to talk about weight. Be empathetic. Don't blame. Listen and explore about what the issues are. And remember that language is power, and we should use non-judgmental, non-stigmatizing language. So, what can we do? I would say challenge it if you see it. I will no doubt, round the room, you will have seen someone living with obesity stigmatized right in front of you and just accepted it. For other issues that we have related to stigma, do we do the same? And I'd like you to start to challenge people if you see it happening. All people should be treated as people and treated with dignity and respect. There should be equal access to quality healthcare, but in a timely manner as well. We know that education and training is absolutely key. This needs to happen pre and post, and in my view should be mandatory in all training. We need to be aware that people are living with obesity are involved in healthcare policies, and language is absolutely key. But finally, I'd like to appreciate that healthcare professionals are also experiencing stigma, and that this stigma impacts on their feelings, on their abilities to actually manage their patients. So think about those relationships you have with patients. I'd like to have these my acknowledgements. Thank you very much, and thank you for listening.
Thank you very much. Great. I think this is an important topic, and we will also discuss maybe a few proposals about how we can change things in practice. Any questions from the floor? Otherwise, I have one. Let's give priority to attendees, please.
Thank you very much, Adrian. My question is, I think I had this question when the first speaker came up, Daniel, but you kind of shed more light on it. So my question is around training. Training is fundamental to shape how we behave, even as healthcare practitioner when we see our patients. I wondered if addressing stigma at large across different disease conditions as part of the training we receive as undergraduates. While in school, I had this question because I didn't have my undergraduate here. I had my postgraduate. But I believe it would shape our knowledge as healthcare practitioners if we're exposed to this earlier on in our training. And then maybe when we then join the practice, we have this as mandatory training.
Yeah, no, I completely agree. And I'm very, very fortunate to be a co-lead for the dietetic program at UCL. And also we're involved in the obesity MSc that was set up by Professor Rachel Batterham and our team. And stigma is mentioned from day one. We talk about weight stigma from day one, and we talk about the importance of language. And so I think things are changing, but not every university in the UK does it. If we look at medical training around obesity, it's hardly mentioned. And so if we start thinking about dietetic practice, it's hardly mentioned. And so I think for something that impacts on a third of our population, 2/3 if we're going to include overweight and obesity. For it not to have a more dominant place within our training, I'm shocked at right at the moment. And I think we need to appreciate that, yes, it's important to talk about other conditions, but we need to be talking about something that's going to impact on all healthcare professionals when they leave practice.
Last question there. Quick question and quick answer.
Thank you. Just a comment more than the question. I'm Ashish Desai. I'm one of the pediatric bariatric surgeons. And what you said is the experience which I find everywhere. So when I started doing pediatric bariatric surgery in 2010 onwards, I wrote to my colleagues because I was doing a conference with American surgeons coming over. And the responses which I got was quite shocking because it was said, I said, if you or anybody else from the department would like to come for this conference. And they said, I can only tell you that till I'm here, nobody in this department will ever do this. All they need is few fried Mars bars. Or if you want me to come, I'll come there and tell you why it should not be done. So, and that has been this experience ever since. The resistance from and these are all knowledgeable, they've done, but they don't have the knowledge of obesity, and therefore they have the same bias which the general population has. So you're absolutely right. Thank you.
Very good point. And I think I can also say that in my training in medical school, I never studied obesity as a chapter in the textbook of medicine. I still just looked recently at my textbook, and it's a risk factor for any other disease, but there wasn't a formal chapter to be studied comprehensively. So I think we as medical professionals don't have the training to deal with obesity unless you go and specialize in it.
100%.
All right.